Hi everyone. This week we're going to learn about breast cancer. A few facts and figures about breast cancer, which I'm sure you know, some of these due to the large amount of media attention that breast cancer does receive. But it is the most frequent cancer in women. One in every eight women have a lifetime risk of getting breast cancer. There was actually an increase of breast cancer incidence since the 1970s due to the widespread adoption of both the postmenopausal hormone therapy and screening mammography. In the last 10 years, women have been refrained from using postmenopausal hormones, and breast cancer has declined, but not to the level seen prior to that widespread use of screening mammograms. So obviously that has done a lot for increasing the incidence. As with all cancers, early detection is key to reducing morbidity and mortality of breast cancer since people do die of metastatic breast cancer. Risk factors, not including the usual ones of obesity and alcohol use and things like that, they include not having children, having their first child after age 30, starting menstruation at an early age, and then entering menopause late. Receiving radiation to the breast tissue to treat an earlier cancer such as a childhood lymphoma. 5 to 10% of patients with breast cancer have the BRCA or BRCA or another genetic mutation. Nearly 2/3 of patients have no identified risk factors whatsoever. The breasts are paired organs. Each breast is a single organ. The breasts themselves are comprised of adipose tissue, fat, and fibrous connective tissue. Behind the breast is your pectoralis fascia, which is the connective tissue that overlies the pectoralis major and minor muscles. The pectoralis minus muscles covers the serratus anterior muscles, the ribs, and the intercostal muscles, which are considered the chest wall. So that's very important to understand what is part of the chest wall. And the pectoralis fascia and pectoralis major and minor muscles are not considered the chest wall. This information is very important since the chest wall is an anatomic landmark when we T&M stage and when the physicians T&M stage. When we assign the site code for breast cancer patients, it is by quadrant, like the face of a clock, or by the nipple, which is assigned C50.0. And then there is the subareolar area of the breast, or the central part of the breast, which is assigned code C50.1. And then there is the axillary tail or tail of the breast, which is not identified on this illustration, but there is a note stating that that would be assigned C50.6. But the tail would be, up near the axilla of the patient. This illustration is a wonderful tool to use when assigning breast site codes, since it uses both time on the clock and the terminology such as upper, outer, lower, inner, etc. Some radiologists use, time to distinguish where the tumor is or the mass is. Others use the quadrants, okay? You don't need to memorize the breast site codes or anything like that. This is just to make you familiar with what you'll be seeing next semester and in your manuals, there is this illustration available. This is an illustration of the breast regional lymph nodes. There are internal mammary nodes near the sternum, and colored in red. So here, right there. All right. And then there are the axillary lymph nodes, and there are 3 levels of those, and those are the ones that are in like your armpit area. Years ago, when they were still performing modified radical mastectomies, the surgeon would actually dissect all 3 levels of the lymph nodes. So that's why it was so morbid for the patients. But currently, usually only level 1 lymph nodes are removed, and then they only take 1 or 2, if possible, which we'll talk about in a moment. But they no longer normally use the modified radical mastectomy. It just hasn't shown there are ways for the same outcomes with a lesser surgery. The other lymph nodes that are considered regional lymph nodes for breast cancer are the supraclavicular nodes located just above the clavicle, and those are in the brighter red, so right above the clavicle bone. So those, even though they're pretty high up from the breast, those are still considered regional lymph nodes or AJCC T&M stage. Almost all breast cancer is adenocarcinoma that develops from different structures of the breast. So approximately 80% of breast cancer will develop in the glandular epithelial lining of the ducts that carry the milk from the lobules to the nipple, which are called duct carcinomas. 10% will arise from the lobules where the milk is produced, which are the lobular carcinomas. And then the other 10% consists of colloid, medullary, micropapillary, papillary, and tubular. Just know that the majority of all breast carcinomas are duct carcinoma and lobular carcinoma. Let's discuss some terminology that is very important when it comes to breast cancer. So non-invasive carcinomas are almost 20% of all breast cancers. They are not palpable. They may be called non-palpable and are found by mammography only. So this is why the incident rate went up once mammography screening began, because mammography is finding these non-palpable cancers, and going from there. So it may appear when they describe the cancer on the mammogram, the radiologist may describe it as appearing as clustered microcalcifications. So it isn't necessarily a mass or a tumor. It just might be these clusters of microcalcifications that don't look right, and then that is usually a sign of in situ cancer or non-invasive. Non-invasive breast cancer can be extensive and sometimes involves the entire section of the breast. So it can be just a little tiny, or it could be, 6 to 8 centimeters in size. So it can be a large, non-invasive, or in situ carcinoma. This is a precursor to invasive carcinoma, and 30% will develop into an invasive carcinoma. Microinvasive carcinoma is when the cancer invades through that basement membrane. Remember when we talked about that earlier? But the cancer is no larger than 1 millimeter or 0.1 centimeter in measurement. This is considered very minimal invasion and can only be identified microscopically. If a patient has multiple areas of microinvasion, it is still microinvasive as long as none of those multiple areas measure more than 1 millimeter. Okay, we never add up multiple areas of cancer for a larger size. Okay, so we only use the largest size when there's multiple areas or multiple tumors. But just know that microinvasive carcinoma means that the cancer is invasive, but it's no larger than 1 millimeter. So it can equal up to 1 millimeters or 0.1 centimeters. Then we have invasive cancer, which is invasive. Also, it can be called infiltrated or infiltrating carcinoma. So invasive means the same as infiltrating. But let's review the major types of invasive carcinomas. First, there's the duct carcinoma, with certain subtypes, as stated before, are the most common invasive breast cancer, so duct carcinoma. Then there's lobular carcinoma, which is more likely to be multicentric and or bilateral or involving both breasts. So lobular carcinoma is the patient is more apt to have more than one tumor of that cancer, what they call multicentric. And sometimes the patient will have bilateral lobular carcinoma. There's lobular carcinoma in both breasts. Then there is inflammatory carcinoma, which is an aggressive duct carcinoma with specific clinical features of being warm, red, and swollen. So this is a very aggressive cancer. It's a type of duct carcinoma, okay? It's not, there's the inflammatory carcinoma, it's like it says, a specific clinical features, okay? So it's not that inflammatory is a histology type, okay? And we'll talk more about that next semester, but just know that inflammatory carcinoma is more aggressive of duct carcinoma, and it's usually a warm breast, red, swollen, and sometimes looks like an orange. Other breast histologies that are less common include Paget's disease, which is a lesion of the nipple and or the areola, which is usually crusty, itchy, and scaly. Sometimes this is misdiagnosed as eczema, but Paget's disease is usually of the nipple areolar area. Then there's cystosarcoma, phylloides, and it's spoken many different ways, so you may hear it pronounced differently, which is a rare, low-grade malignant neoplasm. But the pathologist must state that it is malignant. Otherwise, it is considered a borderline neoplasm and is not reportable. So this can be either, a benign lesion or it can be malignant, but the pathologist has to state that it's malignant in order for us to report it. It's rare. I've seen several cases, so it's not that rare, but it's it's out there. And then there's also the possibility of having a lymphoma of the breast. Most people think of lymphoma as being, involving the lymph nodes, but actually you can have lymphoma of any organ of your body. So there are sometimes when the patient has lymphoma just of the breast. So those are other breast types of histologies that are out there. When the patient has a breast biopsy, the pathology report will include the results of a hormone receptor assay, a test that tells us whether or not the breast cancer cells have receptors for the hormones estrogen and progesterone. Hormone receptors are proteins found in and on the breast cells themselves that pick up hormone signals telling the cells to grow. All right. So a cancer is called estrogen receptor positive or ER positive if it has receptors for estrogen. This suggests that the cancer cells, like normal breast cells, may receive signals from estrogen that could promote their growth as well. The cancer is called progesterone receptor positive or PR positive if it has progesterone receptors. Again, this just means that the cancer cells may receive signals to promote their growth. All right, so these are the abbreviations on the slides that you'll see within pathology report and consults and things like that. So if a patient is ER and or PR positive, hormone therapy would be offered to help slow or even stop that receptor from receiving those signals, and then it won't grow. All right. So in other words, this treatment can possibly prevent a recurrence and or another breast primary cancer. So ER/PR is very important because it determines whether the patient receives hormone therapy or not. If the patient is ER/PR negative, hormone therapy would not be offered to them because they would be taking hormone therapy for no reason. It would not be of any benefit to them. The human epidermal growth factor, receptor 2, is a gene that can play a role in the development of breast cancer. So once again, the pathologist will perform a test on the tumor to test for this protein. The HER2 gene makes HER2 proteins normally. These receptors help control how the healthy breast cells grow, divide, and repair itself. But in about 25% of breast cancers, the HER2 gene does not work correctly. It makes too many copies of itself. This is known as HER2 gene amplification. All these extra HER2 genes tell breast cells to make too many HER2 receptors, which is known as HER2 protein overexpression. So this makes breast cells grow and divide in an uncontrollable way. So if a patient is HER2 positive, their cancer tends to grow faster and are more likely to spread or metastasize or come back and recur. But there are drugs specifically used for HER2 positive breast cancers, which are immunotherapy drugs. More to come on that once again next semester. So just know, once again, the HER2 test is done to determine whether a patient with breast cancer should be treated with immunotherapy or not. Let's review some histologic terms pertaining to lymph nodes that you will need to know. So isolated tumor cells, or better known as ITCs, are single cell or small clusters of tumor cells that are not more than 0.2 millimeters in size, so very, very tiny. Pathologists today can only see these cells because of the new technology and special staining that they do and that's available now that really wasn't around 15 years ago. So it has not been conclusively proven that these cells are actually active metastatic tumor cells. Therefore, if there are lymph nodes with ITCs, these lymph nodes are considered negative for cancer. All right. So just once again, get to learn the terms, know that this is the information that you'll see and you'll need to use in order to assign summary stage and AJCC-TNM stage. These are the terms that you'll see. Then you may have, the patient may have micrometastases of the lymph nodes, which the lymph node has a metastatic tumor in it that is greater than 0.2 millimeters, but not greater than 2 millimeters in size. So this lymph node or lymph nodes would be considered positive for metastatic disease, but considered micrometastases. All right. Kind of like the tumor that's microinvasive, there's only a little invasion. Micrometastases means there's only a little cancer in the lymph nodes. A lymph node with macrometastases has a metastatic tumor in it that the pathologist can see by the naked eye during his or her gross dissection. Of course, this too would be considered a positive lymph node with metastatic cancer. Okay, so just kind of remember what ITCs are, what micrometastases mean, and macrometastases. The tumor grade that is used for invasive breast cancers is the Bloom-Richardson grade, also known and may be called the scarf Bloom-Richardson, or the modified Bloom-Richardson, or the Nottingham grade. Most often I've seen Bloom-Richardson grade and Nottingham, but all these terms mean the same thing when it comes to tumor grade. All right. This grade is determined by the sum of 3 scores on the degree of tubule formation, number of mitoses, and nuclear pleomorphism. Okay, the pathologist gives each one a score from 1 to 3, and then adds up the 3 scores for a grade from 3 to 9. So that's how, once they add up the sum of those 3 characteristics, then that sum decides on what the Bloom-Richardson grade would be, 1, 2, or 3. Okay, so invasive tumor grade is using that Bloom-Richardson, Nottingham, and multiple other names for it. In situ tumor grade is by its architecture. For DCIS, it's cribriform, papillary, comedo, and solid. Okay, so it's just, the grade is a little different for in situ. They're looking at things differently than they do with the invasive. LCIS, or lobular carcinoma in situ, generally is not graded by most pathologists, okay? And I just stuck a picture here that shows the normal duct of the cells in the breast duct, and then what ductal hyperplasia, the cells are stacking up on themselves, and then the atypical hyperplasia, they're even stacking up even more. all right? And then, but they're not invading or anything. And then we have the DCIS, which it's really that whole duct is kind of full of cancer cells. However, they have not invaded that basement membrane. So it's DCIS, ductal carcinoma in situ, non-invasive cancer. And then the last one shows that it's invasive because it has now grown, the cancer has now grown through that basement membrane. When it comes to diagnosing breast cancer, as stated before, screening mammography has, done a lot for finding breast cancer and finding it early. So obviously, mammography is very important for diagnostic imaging. Many times when there's abnormal mammogram, the patient will then sometimes have additional mammogram views taken, and usually have an ultrasound done of that breast, and then kind of looking at it. Through the ultrasound, sometimes the tumors look, different. So it's just additional information that the radiologist can get by using the ultrasound. And then there's the breast MRI. Sometimes, usually the diagnostic imaging is usually the mammogram and the ultrasound. When it comes to the type of treatment, surgical treatment that the patient has, sometimes the MRI is used. It can be used as a diagnostic imaging for certain patients that have very dense breasts or other risk factors that, might not necessarily show up on mammogram or the ultrasound. So, but most often the mammography and the ultrasound is what diagnoses the breast cancer, or I shouldn't say that's not the true diagnosis. Usually it's the biopsy, but that's how the abnormality is found. Obviously, if the tumor and cancer is palpable, then from there, the patient would most likely have a mammogram and ultrasound and then go from there. So the histologic diagnosis, so just because, the mammogram or ultrasound, it can be very suspicious for cancer, but usually the radiologist, there's not enough conclusive, evidence from the imaging that they can really definitely say this is cancer. It's usually suspicious for cancer or very suspicious for cancer, but very seldom do they say this is cancer. I mean, it does happen when it's really bad, but so even though the imaging shows abnormalities, you still need to get that histologic diagnosis. So standard of care is to have a needle biopsy done before taking the patient to surgery. All right. There are different types of biopsies, which include the stereotactic core biopsy, a vacuum-assisted biopsy. There's a needle biopsy where the surgeon can just stick a needle in and, take a piece of the tumor. There's an incisional biopsy, which can be done if the tumor is at the surface of the breast. We'll talk more about that in a bit. Sometimes a needle localization is done where the radiologist puts a needle in the abnormal area of the breast, and then the surgeon uses that to guide the entire tumor. But that is usually done after they have a proven biopsy, positive biopsy, okay? And then there is the excisional biopsy where they try to take the entire tumor out. However, as I said earlier, this should not be done as standard of care unless it's difficult to get to that tumor using other methods. The physician, the surgeon should always do one of the needle biopsies or incisional biopsies before doing the needle localization of the entire tumor or the excisional biopsy. All right, it's just standard of care, and even though there are some surgeons that do not get that needle biopsy, it is standard of care, and there are actually measures out there that help people keep track of that. So those are the different types of histologic diagnosis. Okay, like I said, many different types of biopsies can be done for the breast. A sentinel lymph node biopsy, or SLN, is a procedure used to predict whether the breast cancer has spread to the lymph nodes in the axilla without having to do a traditional axillary lymph node dissection. Remember when I talked about the modified radical mastectomies, they just automatically took out all those axillary lymph nodes. Now they don't do that. They do most often what they call a sentinel lymph node biopsy. Okay, so the first lymph node or lymph nodes, it can be more than one, is called the sentinel lymph node. The term is more descriptive than precise. It's like the sentry on guard. Okay, the sentinel lymph node is the lymph node that gives the warning that the cancer has spread. Okay, there is not specific. The sentinel lymph nodes are not a specific lymph node chain. Okay, rather they are just that first node or nodes that could catch the tumor cells floating away from the tumor. Lymph node mapping helps identify that lymph node or lymph nodes, and a sentinel lymph node biopsy removes only that lymph node or a few lymph nodes that pick up the dye or are what they call hot. Okay, so if the sentinel lymph node is positive, sometimes the surgeon may do an axillary node dissection right away. But if it is negative, then the patient can avoid that more extensive surgery and the likelihood of getting lymphedema in the future. So when all those lymph nodes are removed from the armpit, patients usually get lymphedema, and it can be very, very not fun, and there can be many complications from that. So using the sentinel lymph node biopsy procedure, they remove that first sentinel lymph node, the first lymph node that's going to hopefully catch the drainage of any tumor that's being sucked into the lymphatic system. All right. So now the important thing to remember about the sentinel lymph node is that it should be the first one or first couple lymph node that the tumor's lymphatic would drain to. Okay, so the lymphatics of that tumor is going to go into the lymphatic system, which as we go along the lymphatic system, we have our lymph nodes. Okay, so just remember that the sentinel lymph node is not a lymph node chain. The sentinel lymph node, can be the lymph node of any lymph node in your body, okay? But it's the lymph node that's detected by putting the dye and radio tracer into the tumor, and then they wait for that material to go through the lymphatic system that the tumor would, and then they identify the first one or a couple lymph nodes near that where they believe the tumor would drain into. Okay. So when a sentinel lymph node biopsy is performed for a breast cancer, no matter what lymph node is removed, the sentinel lymph node is considered a regional lymph node for the breast. Okay. The sentinel lymph node is most often an axillary lymph node. Okay. And the sentinel lymph node is usually the level 1 lymph node, which is an axillary lymph node, okay? But the sentinel lymph node may also be a level 2 lymph node, okay? But remember, level 1, level 2, and level 3 lymph nodes are axillary lymph nodes, okay? So as you can see, you know, regional, axillary, sentinel lymph nodes, they're all the same thing, okay? The sentinel lymph node may be an internal mammary lymph node as well, okay? And I'll show you that in a moment. There is a video here of a sentinel lymph node biopsy being done. You do not have to watch it, but it shows, it's not gruesome or bloody or anything like that. They just show how they inject the dye radio tracer and how it maps to that lymph node. So it's a really great visual. I know some people don't like surgeries and things like that, but like I said, it's not bloody, and it's like 4 minutes long. So it's not long. You don't have to watch it, but it's very good visualization. If you do not watch the video, make sure that you click on the link on the previous slide, on slide 19. That link will bring you to some information about sentinel lymph nodes, and, you know, explain it again what exactly a sentinel lymph node is, okay? You might want to print that information off and put it in a binder with your handout here so you can refer to it next semester, okay? So, so now if we refer back to that lymph node illustration that we had on slide 6, and I have here again, all the lymph nodes listed here are regional lymph nodes, okay, and have the potential to be a sentinel lymph node, okay, with the exception of the supraclavicular lymph nodes. The chances that the tumor in the breast would drain first to the supraclavicular lymph nodes is, I don't even know if it's possible. But as you can see, you know, no matter where the tumor is in the breast, you know, think about the lymphatics and where that might, you know, drain to. So let's say there's a tumor just above the nipple, and they do the radio tracer and dye, and the surgeon looks at it, and this is the first lymph node that they see. Okay, and it looks like a blue jelly bean. And so this node, or if there's a couple that are blue, that would be 1, an axillary lymph node, because it's a level 1 axillary lymph node. 2, it's a regional lymph node, because axillary lymph nodes are regional lymph nodes. And it's the sentinel lymph node, because it was the first lymph node that tracer went to, okay? So let's say the tumor was even higher up on the breast, and when they did the tracer dye, this is a lymph node that the surgeon saw and resected. So now we're in the level 2 lymph node, but once again, it's an axillary lymph node. It's a regional lymph node, and it's the sentinel lymph node. So you can see that all 3 are the same thing, all right? And then once in a great while, especially, possibly if the tumor is near the sternum. The sentinel lymph node can be an internal mammary lymph node. Okay, so now you have a lymph node. It's the sentinel lymph node. It's an internal mammary lymph node, and it's a regional lymph node. Once again, one lymph node, but it can be called 3 different things. Okay, so I hope this kind of gets you into understanding this concept. I know right now the second-year students are abstracting breast cases again, and this is just sometimes a difficult concept for some to understand. But the sentinel lymph nodes and any, except for the supraclavicular here, sentinel lymph node, usually axillary, always regional, sometimes can be internal mammary. Okay, so just keep that in mind. And I know I keep saying it, but really keep these handouts so that you can refer to them next semester and then the following semester as well, so that I don't have to say, pull out your handouts from that class and remember, look at that paper. And they're like, oh yeah, right, I forgot about that. So just keep them handy to kind of help with the light bulb going off. So, because I understand it's a lot to know and remember and things like that, but just try to keep that concept in mind. So survival has improved dramatically over the past 20 years, during which time disease management has become multidisciplinary, combining surgery, chemotherapy, hormone, and radiation. So, and then even, reconstructive surgery as well. And you'll learn more about cancer conference and tumor boards and things like that. And it's when all the physicians, the different disciplines get together, discuss cases, and decide, as a group, what the best treatment plan for a patient is. And that communication has really done a lot to improve treatment over the years. So, surgery. I know I included excisional biopsy on the diagnostic, but like I stated before, excisional biopsy should really be used as a cancer treatment for the breast cancer, okay? And the excisional biopsy is, they go in there and they remove the entire, tumor, or at least they try to, okay? And then there's the lumpectomy, okay? So a lumpectomy is, they do a wide excision of the tumor. So they cut around the tumor with a good, measurement between the tumor and where they're cutting, okay? So they're really trying hard to make sure that they get negative margins and they're not cutting into the cancer, all right? However, sometimes when they do a lumpectomy, there might be positive margins. So then what they have to do is re-excise that tumor, or they perform a re-excision, okay? And a re-excision may be for gross cancer, like let's say the surgeon, did the lumpectomy, looked at the breast and went, oh, there was, the tumor wasn't quite the shape I thought it was, and they can still see the cancer. Then they could just re-excise it right away. But usually it's used when the pathologist looks at the lumpectomy and says, oh, the cancer went to the margins. You have to go back and resect that area. So that's a re-excision, all right? Then the segmental mastectomy, that's wider than a normal lumpectomy would be. Okay, so it's taking more breast tissue than just the lumpectomy. Most physicians do lumpectomies. I've only actually seen a couple surgeons that actually call it a segmental mastectomy. And then there's the quadrantectomy, and they're removing 1/4 of the breast. Okay. Once again, I have not seen that often in what I've abstracted, but I'm sure it kind of depends on, you know, how the surgeons were trained and things like that. And then there's the mastectomy, okay? And there's one called the subcutaneous mastectomy, and that removes the breast, but it's leaving the skin, the nipple, and the areola, okay? So they're just taking basically the inside of the mastectomy. So subcutaneous, they're leaving the skin behind. And not all patients can have this. If the tumor is close to the skin or nipple or areola, then they would have to remove that. But doing this type of mastectomy also helps with reconstruction. So, especially, you know, keeping their own nipple, they don't have to reconstruct that nipple. So that's subcutaneous mastectomy. Then we have what we call a simple or total mastectomy, okay? That's what is most often done nowadays, okay? And they just remove the entire breast. The modified radical mastectomy, sometimes if patients have positive lymph nodes clinically, this might be done where they remove the entire breast, but it's also removing that axillary tail with the axillary lymph nodes, okay? So they, if a patient has a mastectomy with a sentinel lymph node biopsy, what they usually do is that simple or total mastectomy, remove just the breast, and then they do, you know, before they remove the breast, they do the mapping of that sentinel lymph node and just take, you know, those couple, 1 or 2 or possibly 3 lymph nodes, and it's not all one end block. It's not all one piece of the breast like they're taking with the modified radical mastectomy. And then you have the radical mastectomy where it's the entire breast and the underlining pectoralis major and minor muscles and the axillary lymph nodes, and it's all in one piece, one en bloc piece, okay? But that one is, you know, they are taking those muscles away. So that is very seldom done, even if a patient has a tumor that's invading those muscles. They usually have them receive neoadjuvant chemotherapy prior to try to shrink that tumor so that they don't have to take as much of the muscles as they would if they didn't have the chemotherapy. So those are the surgical treatments that can be done for breast cancer. Then there is reconstruction, okay? And there's 2 types of reconstruction that can be used. There's the natural one or man-made. So these are just, you know, the 2 materials, either natural materials or man-made materials to restore the contour of the breast or breast. Implants are man-made prostheses created from inert plastics and filled with saline or silicone. And this reconstruction is usually done in 2 stages. I'm sure that with all the publicity of implants and things like that, that we all kind of know what an implant looks like, all right? But that usually is done in 2 different stages. And then tissue is a natural reconstruction that uses the muscle and skin from the patient, okay? There is the tram flap, and that's using the abdominal skin and the transverse rectus abdominis muscles to form a new breast. So they basically take that area of the abdomen and just twist it around and make it into a breast. And then there's the latissimus flap using the tissue from the woman's back muscles, the latissimus dorsi. So those are the different types of reconstruction surgeries that can be done. All right, so just remember, the man-made, the implants, and then the tissue is when they are using the patient's tissue themselves to reconstruct. Some women, really want to have that reconstruction. Is very important, and then there are some other women that they don't even care. So it's always interesting when you're abstracting to read the patient's, perception and perspective of reconstruction surgery. It's always very interesting. So then there's radiation therapy. So radiation therapy is given to women that have breast conservation surgery or a lumpectomy. So breast conservation surgery, whenever you hear that, that means that the patient had a lumpectomy. They only removed the tumor with a good margin. They did not remove the entire breast, all right? So they still have breast tissue there. So depending on the type of breast cancer and the patient's age, if the patient has a lumpectomy, they most likely will also have to have radiation therapy. Okay, it's been proven that a patient can have a lumpectomy with radiation therapy, and that has the same outcomes as if a patient would receive a mastectomy. So it just kind of depends, depending on the type of radiation you have to the breast. It can be up to 8 weeks of treatment. Some people, don't want to do those daily treatments and things like that. So, if someone doesn't want that extra step, then they most likely will decide on a mastectomy. So when they do the radiation for breast conservation surgery, that is beam radiation, 4 to 6 weeks of treatment, all right? But then there's also a partial breast radiation that can be given after a lumpectomy, and that's using the Mammocyte or the Savvy. And there's links that will bring you to videos that demonstrate each one. There are two very different partial breast radiation treatments that are out there that a patient can have. And a patient using one of these, it's only 5 treatments. So that's usually like Monday through Friday, and they're done instead of, 4 to 6 weeks. Please watch those just so you get a better sense of what partial breast radiation is. Also, the acronym PBI, partial breast irradiation. So then if a patient has a mastectomy, sometimes they still have to have radiation therapy. And if the tumor is greater than 5 centimeters, they'll normally have to have radiation. Now that's depending on, the patient's age and the risk of them dying from a recurrence and things like that. But that would be an indication for someone that had a mastectomy to still receive radiation therapy. And if the patient has 4 or more positive lymph nodes, then they should receive radiation therapy. And then if the tumor was really close to the chest wall, they should also have radiation to the chest wall. All right, so there are still times when a patient may have to have radiation therapy even when they've had a mastectomy. Chemotherapy is once again given to kill any residual microscopic disease that a patient may have after surgery. Breast cancer patients would also receive chemotherapy if they are ER/PR negative, since they do not have that option of receiving the hormone therapy that we talked about. So it's been proven that these patients, since they can't receive, or they could receive hormone therapy, but it's not going to do anything, since hormone therapy won't be of benefit to them, that if the patient is ER/PR negative, they should receive chemotherapy, or at least be offered chemotherapy. If the patient has positive lymph nodes, and if the patient has a large tumor that needs to shrink prior to having breast conservation surgery, or once again, like I talked about before, the tumor is close to the chest wall or invading the chest wall, then sometimes that chemotherapy is given prior to surgery, given as a neoadjuvant therapy to shrink the tumor. There are sometimes where if they didn't receive the neoadjuvant therapy, then the patient would have to have a mastectomy. But if they receive neoadjuvant therapy, sometimes they can preserve that breast and only have to do a lumpectomy. Hormone therapy would be offered for those patients that are ER/PR positive, and then the immunotherapy would be offered if the patient is HER2 receptor positive. Okay, and remember that whether a female or a male, the treatments would be the same. Men do get breast cancer, but and obviously for a male, the only difference probably would be that they would do more of a mastectomy type surgery than a lumpectomy. But basically, the treatment is the same whether male or female. There are a lot of breast site specific data items that we collect. And the breast does have the most to collect. I believe there's more than 20. I kind of put a couple together here, but there are more than 20. And some of them we talked about throughout the presentation, the HER2, ER/PR positive, things like that. So remember, you don't need to know these, just know that next semester, you'll be coding some of these, not all of them, but then your last semester, you'll be assigning codes for all of these data fields. So breast is a lot more, even as you can see, this presentation is taking longer because there's just so many more treatments for breast cancer and different sequences that you can do it and things like that, it's a lot more to know for breast cancer. So this week's assignment is a little different than in the past. So just go to the assignment tab. It just says, pick a subject that interests you pertaining to breast cancer, and write 2 to 3 page, or 2 to 3 paragraphs, not pages. Just 2 to 3 paragraph summary of, what you learned. Make sure you cite the source that you use, and remember to use a legitimate website as well, or manual, textbook, things like that. It can be about pathology, the treatment, different types of surgeries, radiation, including the Nanosite or Savvy, different types of immunotherapy. At one time, there was only one immunotherapy. Now there's several out there. And there are different types of hormone therapy too. There's hormone therapy that If a patient is premenopausal, they would receive that type of hormone. If they're postmenopausal, they would receive a different type of hormone. So that's very interesting to learn about too, as well as the different types of reconstruction. So just pick something that you're interested in learning more about. Just make sure that you pay close attention to the grading rubric that is under the assignment instructions, because that's exactly how you will be graded on your paper, okay? And stuff is, there should be certain type of formatting and things like that. So just make sure that you read that carefully. Also, you have a second assignment, and don't laugh at it, but it's very important. Like I told you, my students this semester are struggling, and every time we do a breast case, they're like, is the sentinel node, the axillary node, or today someone said the sentinel node cannot be the regional lymph node, right? And it's like, oh boy, so don't laugh at your assignment too, but it's very important. And I want to make sure that you guys, that it really sticks in your head, and next semester you won't be stumbling over that part, okay? So I realize this presentation was longer than they normally are, but there is, so many different treatments with breast cancer. So hope you have a great week. If you have any questions, you know where to find me. Take care.